We will present a case of adenomas, multiple adenomas that you've already seen, and we did exactly as we did, as you suggested, but in fact the patient didn't. Isabella, yeah.
Yes, thank you.
Because she became pregnant while we had not finished the treatment. And now she wants to keep the baby. Right, Isabel.
Of course. Thank you. So good afternoon to all. As the professor already said, we already discussed this case. Oh, sorry. Yeah, this case last year of a lady in her 30s, obese, with a BMI around 36, and she was taking anticonceptional pill after already 2 pregnancies. At that time, she was admitted in our ward because of a hemoperitoneo after massive bleeding of this large hepatic adenoma in S8. So at that time, we went for a conservative management of the bleeding. She recovered very well, and we recommended from the first time to avoid completely the oral contraception and to try to lose some weight. So few weeks after, she did this hepatic MRI, finding many adenomas in the liver, and especially we were warning about the one in S6. That was the reason why we discussed this case with you, and you suggest what we actually did for preventing the risk of rupture and again bleeding. We embolize this lesion in S6. We stick to the main recommendation of lose weight and waiting for the opportunity of the resection of these 2 main lesions in S8 and S6. So after a complete recovery, the hemoperitoneo was gone, the BMI was around 36, and so we went for the robotic resection of the lesion in S8 and S6 that at the final pathology were both inflammatory hepatic adenoma with some central necrosis and fibrosis. So again, we recommend of losing more weight and avoiding completely the oral contraception. We follow up her in the outpatient clinic, and we did the last imaging in December of the last year. But the update is that she came back a few days ago to us announcing that now she's pregnant, almost 6 weeks pregnant, with now a BMI of 31. And our warning is the remaining lesion and the remaining adenoma in the S4, because this lesion was shrinking during the months at the time of the surgery. So as you can see here, it was 3.7 at the moment of the diagnosis, but she was already 2.8 in the intraoperative ultrasound. And for this reason, during the operation, we didn't go for a section also of this lesion because the dimensions were lesser, and there was already an irrelevant intraoperative bleeding due to the resection of the other 2 main adenomas. So we decided not to resect this, but just to follow up it and to convince the patient to lose weight and to avoid the contraception. And in the last imaging, it seems that the lesion was stable, almost around 2.9 centimeters in December, so 2 months after the resection. Now she is pregnant, so our warnings are about this lesion and how to follow up it or what to do with it. We were wondering about the ultrasound follow-up during at least the first trimester. Since she has lost more weight, we should have a nice echographic window to see the lesion. and maybe do a liver MRI in the second trimester, and just to evaluate if we should go for a surgical resection or not. But here we would like to know again what you think about it, what you should do.
Right.
Okay. Let me check. There is only this one on the left liver. Is it?
Yeah.
Just one? Okay. These 3
Is there
centimeters,
anyone?
3 centimeters, okay? And
Yes.
very small one. Okay.
There are others.
There are a few small ones.
Yeah, very small.
But
So
the 3.5 centimeter has become a 2.9 with weight loss and stopping the contraception pill. But
okay.
Alessandra did not feel, after the struggle with the 2 other adenomas, she felt that the operation had gone on too much, with quite a bit of blood loss, and she did not feel appropriate to tackle that. Also because it had been reduced in size, and
Okay.
yeah,
that was fair.
It would be nice to have it resected, but we give up the hope for a better past.
Okay. I think it was fair not to resect at this moment. And now you know that logically a lot of teams said that most of the adenomas are uneventful during pregnancy, but this one has clearly a propensity to bleed. So it's a very dangerous case, I agree. But as I told you previously, resection in a liver during the pregnancy is not an easy one, because the liver is not a normal liver. It's really like a vascular liver. So to my opinion, I wouldn't resect it during pregnancy. You have 2 options. The first one is not to do anything and just follow up. And probably, well, maybe it will remain like that. But, well, you don't know. The second one, because it's 3 centimeters, is to do some thermal ablation. Thermal ablation is possible, microwaves or radiofrequency. It's easy there because it's not subcapsular. It's far from the biliary tree. Well, it's safe to do that. And it's, to my opinion, to be, what I say, to be safe and to be not worrying. I think that radiofrequency now is the best option for this lady.
Yeah, thank you very much, Laurence. Anybody has any other thoughts? I'd be much more.
I have a question. Can I ask a question?
Of course,
Sorry.
Alessandra, it's your patient.
I just wanted to ask if Madame Chiche thinks that it's safe to do the ablation during pregnancy.
Why not?
It's just a question. We haven't performed any before, so it's just a general question.
I think there's no. It's not more dangerous than an MRI for me. No, it's not. It's not.
Okay, thank you.
It's not dangerous. I did it before.
Thank you.
By which way the ablation?
Percutaneously.
Yeah.
Obviously, it's easy there. It's just in front. It's not a very difficult procedure.
There is a comment that we read. Microwave thermal ablation is safe. I don't know who said that, but I saw a message appearing. If you want the person who's posted the message, if he can speak. No, we're just left with the laconic thermal ablation is safe, right?
Yes,
I just wanted to add in terms of the ablation. I don't know what technology you guys use, but we right now use this navigation system, which requires laparoscopic approach. But the advantage is that this system allows you to
Dimitri, we didn't hear anything.
yeah.
The needle is placed and you can of the ablation. So it's I've done a fair number of those, and then it's kind of a game changer in the sense that it's virtually 100% one-time needle placement. You don't need to replace it because it really tells you where you are. So laparoscopically, and in pregnancy, it shouldn't be a problem because laparoscopy in pregnancy is done routinely for appendectomies, gallbladders, and things like that. Shouldn't be a problem at all. And it's very easy. It's just literally a camera and the needle insertion plus the ultrasound probe. So it's like, two small ports and one needle stick. So it's just totally fine. But I want to second Lorenz. I just literally this week did a very similar case, which I was going to save for next month. And I did the ablation for 2 lesions and I resected one. It's a similar case to this, but maybe I'll change what I was going to present in Paris. But I think it works really well with the microwave for adenomas, and I've done radio frequencies in the past as well. Works pretty well.
Good.
The only problem in radiofrequency when the adenoma are a little big is to have an abscess. It could be. We have that.
Correct.
And that can be a problem, but even if there is an abscess, you can drain it after. So it is a complication. It's the only complication here, but it's not a very serious one. You can manage it percutaneously also.
I haven't done a radio frequency in I don't know how many years because we've switched to microwave for probably at least 10 years. But I think in all the radio frequencies that I've done, and I used to do a lot more than now, I think I had 2 abscesses all in the entire career. So it's very rare.
Yeah, it's rare. It's when it's big.
Yeah.
But I think this generation, my generation, speaks of radio frequency because we got used to the term, but has almost disappeared, and we use microwave, and we use it synonymously. Thank you very much indeed.
I just have one more question about this because I'm a little curious. Obviously, for true malignancies, microwave and radio frequency, they have a pretty clear limit in terms of the size. But in a benign tumor like that, what do you think in terms of like 2 overlapping ablation for larger lesions? Would you do it if it exceeds 3 centimeters and it's in a bad location and you don't want to subject a young patient for a major resection? What's your opinion on that?
For benign lesions, we do not have any need of a margin. So you can do a lot more than for malignant one. The problem with microwaves, it's that it is proved that the margin is less. It's not very good compared to surgery. Anyway, you can check it very well. So for metastasis, for example, they said for 3 centimeters is okay. For 5, you have to do a multimodal radiofrequency, but it is, of course, a very big area of destruction. So the more the bigger the area is, the more complications can happen, particularly concerning the bile duct. If you have 5 or 6 centimeters, you have the area of a segment. So of course you have some problem with the bile duct. It's not always a real problem, but it can be. You can have biliomas, you can have a stricture of a bile duct. So this is the only problem to expand the area of radiofrequency or microwave. Microwave, of course, in France also has replaced radiofrequency because it's easier, it's faster, and it's more efficient, of course. And we say radiofrequency, but of course, the problem is the danger that a microwave is used now for very big lesion, malignant one, and the risk of recurrence in the area is quite high if you do over 3 centimeters.
No, but
But not
Lorenz,
for malignant.
yeah, but I'm talking about obviously for malignant lesion. We all know that there's a limit, and I mean, there are people that do things, but there's a lot of people that don't follow the guidelines and so forth. But I'm just talking about in the settings of an adenoma benign, and since we're talking about the ablation, would you consider, let's say, 4.5 centimeter tumor that is obviously exceeds the limit of the ablation, so to speak? Would you do like 2 overlapping ablations in a patient like that, as opposed to putting this patient through a complex hepatectomy, like if the lesion is like,
Yes.
let's say, well, that's what the question was.
Yes, as I told you, for adenomas, for benign lesions, the margin is not really a concern. So, of course, yes, if the hepatectomy is dangerous, I would prefer thermal ablation. You're right. I agree with you, Dimitri.
Thank you.
Good. Thank you very much indeed. Any other comments from somebody else? Well, it's a real pleasure to have this kind of expertise available for our patient. And Laurence, can I give you the chairmanwomanship of the meeting, because I have to abandon it, unfortunately, but you have to turn on the microphone.
Okay, I can do that, of course. It's my
Thank
pleasure.
you.
So is there any other, I think that Dimitri, you have something to share with us, yes?
Yes, I have a case.
Please. We are listening to you.
Thank you. Let me see how I can share the screen. Okay. Let's see which. Okay. Okay.
Great.
Can you see it?
Yeah, perfectly well.
Okay, great. So it's a little interesting, to me at least, case. So it's a 45-year-old gentleman who is in excellent performance status, very athletic, and in great physical condition. 45. So 2 years ago, started having some sort of abdominal complaints. He lives between United States and Russia because he's the agent for the NHL hockey players. So he brings all the Russian hockey players to the United States to play. So he's traveling freely between the two places, which is amazing to me. But in any event, so 2 years ago, he had some abdominal complaints and underwent.
We can see only your first introduction slide.
Yeah, no, I haven't moved yet. So
Okay.
I'm giving you the background before what's happening. So that was 2 years ago. So he underwent low anterior resection in August of 24, and the tumor, which was done in Moscow. The tumor was well-differentiated adenocarcinoma, T3N0M0, BRAF, KRAS, and RAS negative, and MSI stable. So he didn't receive any adjuvant chemotherapy and was in full remission. So in February of 26, which is now, he undergoes a surveillance scan, and that's what it shows. So let's see. He's got 3, potentially 4 lesions in the liver. I'll give you another view. Maybe one more, just for good measure. So, so this is February, okay? You get the picture. So it's 3 big lesions, essentially in every lobe of the liver. That's a coronal view, real quick. So he, he comes to us, and he got 3 cycles of FOLFOX. Now CA is 10. Last week, which is very impressive. So the reason I'm presenting this is because he is insisting on surgery, and I just want to get everybody's opinion in terms of, would you continue chemotherapy since there is a response, which probably makes sense? Would you consider, now that these things are small, to perform a laparoscopic ablation? And obviously, I understand that in Europe you don't have this option, but here in the United States we have an option of a intrahepatic chemotherapy pump placement. So there's a myriad of options. I'm not including other things like Y90 and stuff. So I just want to hear everybody's opinion. What would you do at this particular stage?
Okay, the discussion is opened. So who wants to discuss it, please? I don't want to begin, so
Why
please. Okay, I can open the discussion. Okay, this is a very interesting case because it happens more and more often, because the chemotherapy here is really effective. But we have, to my opinion, we have to remember that resection is the best option, a best curative treatment today. So the first question is it resectable? the answer is yes, it is resectable, and it's not really difficult. The second point is, do we stop the chemotherapy, which is very effective, or do we continue? That's a very good point, because it's very effective. But you understand that if we continue, the smaller one will disappear. So it will be very, well, difficult after. So, and the third one is the choice between resection and, of course, thermal ablation microwave. If you can put the last CT, please. Because Dimitri, you privilege, you said always laparoscopic radiofrequency. Why do you do that only laparoscopically? It is possible percutaneously. Your micro is closed. Your micro, please, Dimitri.
Yeah, may I say something, Laurence?
Yes. Sorry, I don't know. Once I click share, the micro disappears.
Okay.
Which probably is logical, because if you're sharing, you should be speaking. So let me reshare it again.
Yeah, please.
So reason for percutaneous percutaneous versus laparoscopic. Yes, you can do percutaneous, no question about it. The problem, not the problem, but essentially the approach here is that with this new navigation system, it's so much more precise that
Okay.
I feel that for certain things it's better. But let me explain also, because you have to be objective and honest. And honesty will tell you that the hospital would prefer laparoscopic ablation, because the reimbursement for the hospital on a laparoscopic ablation is essentially 10 times more
I
than
understand
on
that.
percutaneous from the insurance company.
Okay.
And so they favor that as well. So
Okay. So to continue the discussion, you have the biggest one, which is near the portal trunk. They had
yes,
a dilatation of the bile duct. I think that resection would be preferable for this one.
so this one is a no-brainer. Okay, that one is easy. You're talking about this one,
Okay.
right?
But this one is really, really very near the bile duct and the anterior branch. So I would prefer a resection. For me, it's better. It's better for the margin. It's better for the safe approach. So I would prefer a liver resection for this patient to cure. And we remember that 3 metastasis is a good prognosis for liver surgery. So I think that somebody, Professor Bismuth, you can discuss the point.
No, I was discussing the moment of the operation, before the technique of the operation. So you said, Laurence, that now I think she received 3 cycles of chemotherapy. Is this correct?
That's correct, sir.
And the chemotherapy was very efficient. Okay, tumor marker decrease, but the question is, if we wait more, maybe we gain something. So the question is, what kind of resection we will do now, and what kind of resection we will do if the tumor is smaller. If there is no benefit, that means if the resection is the same, why to wait? But if we modify the resection by doing a smaller resection, at that time, could be there is some benefit to wait. But this is a question that I write to both of you.
Well, the proximity of these lesions say that even if it's smaller, the resection will be the same. This one, for this one, the one we see now. It's very near.
I think you can take out the anteriors, right anterior portal, and keep the posterior intact.
Yes.
Exact.
Because
Fernando is want to say thank you. We are hearing you. Okay.
Well, good morning to everyone. At least in Argentina, this is very, very in the morning. So thank you very much. Dimitri is an excellent case. I think this patient is 45 years old. It's has an early recurrence and it's triple negative, right? And it has 3 lesions.
it's 2 years after. It's 2 years after an
2
original
years
surgery.
after, not early.
2
Okay.
years. 2 years.
3 lesions. He has a good prognosis, as Madame Shish has said, and to me it was resectable at the beginning. So you're doing perioperative chemotherapy, in fact. So if we go to the protocols, is 6 cycles before, 6 cycles after, or you don't need really to do 6 cycles before surgery. You do a scan at 1.5 months, 2 months, and if it's responsive and it's still resectable, you could do resection. So I think I would really offer resection. The tiny lesions that were in segment 4B, very near 3, and the one in segment 5 are going to disappear if you give more chemo. And we know that even if they disappear on images, it's very rare that you have a complete histologic response or pathological response. So I would offer resection. And I think the lesion it was very near or in contact with the right anterior pedicle. It is still very close, and you could either try to detach it, or I think it's better to resect the whole anterior right 5 and 8 segments, and then do a tiny resection in segment 4B near 3. And I think it's the best, and I would do it right now. I don't think I would do more chemo, honestly.
I agree. I just wanted to make sure that everyone thinks the same way, because I was thinking that indeed you can get around that anterior sectorial branch. Also, you could see it on the scan that it's pretty much extrahepatic, the secondary bifurcation. So probably will not be technically very difficult to get that. Or you can also do the glissonial approach, but whatever. I'm just trying to see if I could do this robotically. And that would be the most kind of difficult decision to make. But I think we can try to do that.
Excellent. And then you should do the 9 cycles that you have to continue for the perioperative, strategy of chemo.
Right. But I think it's a very interesting case because the response to the treatment is absolutely tremendous, and it's rare. I mean, I don't see this that often. So I was extremely excited to see this.
Yes, but it responds to FOLFOX.
Yes.
Right? So now we have those response with triple chemotherapy, adding, some therapy like Avastin or bevacizumab, etc. And now we have more and more cases like that. My question for you is, what is whether the indication in the United States of intra-arterial chemotherapy, because here we use it, but it's not with the same chemotherapy. We use it when there is a lot of very small metastasis, and we know that in that case, it's not a very good result of surgery, because there are a lot of lesions, and they really can be cured by intra-arterial chemotherapy. And the second indication is the adjuvant treatment, when there are a lot of of metastasis, and you want to try to clear all the liver after surgery. So what are your indications in your country?
Well, I can't speak for the entire country. I can only speak for our hospital system of 28 hospitals, which now created sort of whole pump tumor board, pump protocols, pump panels, and things like that, which is very, very well controlled and strict. So number one, you cannot have any extrahepatic disease. That's considered a contraindication at the moment, at least in our system. I know people do it, but for the most part, you have to prove that it's only in the liver. Just exactly like you said, in unresectable disease, bilobar multiple lesions. And in some scenarios, it is used, just, I haven't done it that way, but people have done it where they've resected enough lesions, like multiple metastasectomies, and put a pump as a complement of adjuvant therapy post-op. I can't say I support that much, but people have done that as well. But otherwise, it's the indications the same way you described. The one thing is that I'm not sure if you have these intraarterial chemo ports in Europe that are just would allow to adjust to attach the pump externally, but we don't have that. So the pump has to be implanted, and it's not that easy, these pumps, because they have a lot of complications. They erode into surrounding organs. I've had a couple pumps eroding into the stomach with pretty massive bleeds. It's not that easy. I have also seen the pump flip. It's actually unbelievable. You attach it to the fascia very well with Prolene sutures and things, and all of a sudden the patient is referred back to you by oncologist who says that I cannot access the pump, and then you call an interventional radiologist to access it, and they stick the pump and they can't get into it, just to realize that the pump flipped on itself, and that's fairly common scenario. I can't say it happens all the time, but I've seen enough of that to know. So it's just not that great and that easy. And implanting it, robotic implantation of it is fairly straightforward. But one of the challenges has been, because like in the past, we started using like the first one, the pumps first appear, we used methylene blue. And once you inject that through the pump, everything's blue. So it's very, very, very difficult to distinguish if there is a true leak or in terms of like the right gastric artery or some other branches. And then, so now with ICG, it's a lot easier robotically. But the company has been a little bit resistant to use that. So now it's coming back to approval, and people starting to use ICG, those who do that robotically. Robotically, it's obviously, once it's done robotically, it's a easier thing to do than a big open operation. I always felt that to do it, just big chevron incision, just to put that catheter in, it was just really, to me, was pretty horrific to do.
Yeah.
But now with the robot, it's easier.
Let me ask you this question. You said bilobar multiple disease are indication for intraarterial chemo without extrahepatic disease. So what's the distinction of the intraarterial chemo versus transplant? What are the things that you are considering to the team to say this is for transplant, this is for chemo, this is for HAI? do we have the clear stratification now, or is this just both an equal option for the patient population with biloba, multiple, small disease, diffuse disease?
Well, I think the indication for transplantation, from what I've seen, obviously I don't do transplants, but patients that we refer for transplant are the ones that have demonstrated no progression for at least some time and have stable disease on treatment. And the big discussion is whether the pump is a good bridge to transplantation. The problem that the pump creates is obviously arterial damage, and dissection of the artery might create some technical difficulties for further in transplantation, requiring some more creative reconstruction options.
But what's about it in France?
Pardon?
I have. Who's talking?
France.
Who's talking? Just to think to answer to Moaki. In fact, the great difference is that liver transplantation is a curative treatment. However, arterial chemotherapy now is not considered as a curative treatment. So the indication for liver transplantation are very strict. It has to be exclusive to the liver. It has to be a young patient, possible transplantation. So if you can cure the patient with multiple disease responding to the chemotherapy, less than 3 cycles, and with a very low markers, it is an indication if the patient is young. And the arterial chemotherapy is only, as Dimitri said, sometime a bridge. But it's not at all the same option. The one is to try to stabilize the disease. The other is to cure the disease. The second point, we had exactly the same problems with the pump, the arterial pump. It's a very rough treatment for the patient. And now in France, we gave up the pump, the catheter, and we are doing the arterial chemotherapy by radiologist each time with a catheter, and we remove the catheter, and for the next time they put again the catheter. And of course, the problem is the arterial damages of all these procedures. But on experience, we can't do arterial chemotherapy very, very long. It's toxic, it's a little dangerous, and we have some biliary problem after. So it can't be a chronic treatment. It's only adjuvant or bridge to another treatment.
Yeah.
In France, in our department.
So Dimitri, you think when the patient are started on a pump, at some point we can just stratify or maybe randomize them to continue pump versus transplant? Would that be a viable sort of, protocol? Because I'm
sure that would be very interesting to try. But I think realistically, what's going to happen, I think that you will have the pump group to fall out. The patients will either progress, die, or develop pump complications from fibrosis, from biliary complications, all sorts of things. I think your transplant group will.
But the transplant may have an early recurrence, and then up losing the benefit of transplant. So it's not necessarily transplant is better than pump. That is not known. I'm just saying like a Dimitri's place that don't have a transplant as an option. So the pump is a sort of primary measure, right, on this case.
Correct.
But whether or not those patients should be left on pump for too long time, maybe if it's in a 6 months time, I think we can still safely do transplant. Arterial damage is part of that. Then maybe we should randomize. Would you be
I would be
interested in that kind of?
I would be totally open to do something like that. Of course, yes.
Yeah, and I think that should be something also Europeans should consider on the same way. You can also randomize to transplant versus pump at the first place, because the Rooney Adams study was the systemic chemo versus transplant, but the pump has to be also compared with the transplant head to head. So that's might be one other option of clinical trial. I don't know
Well, I
which
think
is.
actually it's very interesting because transplant's not benign either. You still have probably 10 to 15% mortality first year, and the pump as well. So it could be, and if the trial is done properly, we could come up with the results that it's equal or similar. It's very interesting.
Just a
But
remark that the recurrence after liver transplantation is extrahepatic recurrence.
Yeah.
That's it.
Yeah.
So it's
No.
not the same.
Yeah, no, it's not the same. But if you continue to pump, you are avoiding the major surgery such as a transplant. And if you have the same, OS, the overall survival, from that intention to treat analysis, then it's really not that much transplant is superior.
I get it, but we use a lot of intrahepatic, and the fact is that it's impossible to go on with this treatment very long, because at the moment there is a toxicity. So in the randomized study of René Adam, for the person who had only chemotherapy, they use chemotherapy for years, and it's impossible with intra-arterial chemotherapy to use
But
that.
we also have to compare sort of apples to apples, because what we put in a pump, it may not necessarily be the same thing that you put in radiological intrahepatic infusion, because the pump is only FUDR, and you could probably do platinum agents, right?
Yeah, but even considering pump cannot be continued for a long time, that could still be a valid trial, right? If the transplant is clearly superior to pump in that way, then it's something, right? Even
Okay.
Yes, I agree.
the rates still be low, but it may be, that is high enough to maybe, overperform the pump, or maybe not,
But coming back to the patient that I presented, I mean, this patient should undergo resection, and that's it. This is not a transplant patient. We all agree on that, right? Yeah.
Of course.
Of course.
Thank you very much. Is there any other observation? Any case? No? Nobody? I see the participant.
I have one more case.
Oh,
yes.
Silvia.
Silvia,
Hello.
yes.
Sorry.
Nice to see you. Okay, we are listening to you.
Oh, thank you. I will share with you. Could you please give me... Everyone is seeing?
Yeah, it's okay.
Yeah. Okay. So this is a pancreatic case. So change the subject. We have a male patient, 28 years old, no medical history, that starts 10 years ago with mild hypoglycemic episodes. But recently, coincidentally, with an increase in exercise, these symptoms starts to increase. This patient is a physician, so he buys a sensor and starts to monitor the glucose levels. Frequent glucose levels very low, 55 to 65. The lowest record glucose of 43. Occasionally nocturnal and morning readings under 60. All the blood tests are normal, and he performed the CT scan that I will share with you. And as you can see, we have a few pancreatic lesions, cystic lesions, and some calcifications, dispersed calcifications, and these two major lesions on the head, this one on the head, and this one on the body, and a few more on the body. So we performed an MRI to confirm these findings. And I will show you other face. So we have calcifications, a lot of small cystic lesions, 4 small nodules, one in the body, 1 centimeter, and another one, 1.2 centimeters on the body. No dilatation of the Wirsung, and no other features. So at this point, I will ask you, what would you do?
Sylvia, do
Anyone?
you mean that we have multiple insulinoma?
We think so. We don't know yet, but we think so.
But why do you? What are you talking about? IPNM? It's
we have IPMN and other lesions. We have cystic lesions and solid lesions.
Okay, but the most important is the solid lesions.
Yes.
The problem of the patient is multiple insulinoma, right?
Yes. Yes.
So did you perform gallium scintigraphy?
Yes. I can go further.
Yeah.
We performed the more blood tests, and we see that you can see here we have a normal insulin level with a very low glycemia. So this is not normal, and it seems to be like an insulinoma with a high glucagon levels. So we performed an ultrasonography, and we can characterize these lesions, the biggest lesion in the body, and another lesion in the head. So we performed a biopsy, and that confirms in the pseudonodular lesion in the body a well-differentiated neuroendocrine tumor, a G1. So after that, we performed this PET-NOC, but we can see an increased somatostatin receptor expression diffusely all over the organ, all over the pancreas. So not only on that lesion on the body, the biggest one, but in all pancreas. So now I ask, what do you think we can do for this patient, this very young patient with only 28 years old?
Excuse me, I don't understand. This dirt attack, this dirt attack is not usual. You have I don't understand the dirt attack. that all the pancreas is stained? All the
Yes,
pancreas?
yes, all the pancreas. Increased somatostatin receptor with an SUV very high in the head and tail.
Well, Sergio, you have something to
Sorry,
say?
I don't see you.
Yeah,
I'm sharing already. Sorry,
No, you don't.
sorry,
okay.
this is
Yeah,
not working well. Yes,
yeah.
Yeah, we
You
see.
can practice left pancreatic resection and enucleation of the lesion in the head of the pancreas.
sorry.
If you can do left pancreatic resection
Distal
and
resection and enucleation of the head.
mhm, yes, it's a possibility.
In the
Well,
head, it's in the head. Show me the head. The little insulinoma in the head is really not easy to enucleate, is it?
No, it is not.
I'm
It is
sorry,
deep.
but I think you have not yet are at the stage when you can perform surgery because you have lesions that maybe light up on a dotatate scan, but you have no idea which one is the secreting one and which one is not. Some of them are not. So what I would do is selective calcium stimulation test to to localize the lesion, to do sampling from the splenic vein and a portal vein, and you could see where the levels of insulin will be different. And maybe you can select one of those two lesions, or one of the at least regions of the pancreas, which is more secreting than the other. And maybe one part of that is not secreting at all. And so that's one thing. And actually, if you cannot truly localize the lesion, I mean, here you see it, but you don't know if what's on dotatate positive is what's causing the symptoms. So you still have to document this chemically. And once you localize it, then maybe you can do either distal pancreatectomy or a Whipple, depending on where the stimulation is high, because it might not be. And then the other thing that we've done quite a number of EUS guided radiofrequency ablations.
Yeah.
Or small lesions, and that could be very effective, because I think if all these lesions are secreting, which I honestly doubt, then the only curative operation would be a total pancreatectomy. But for a 28-year-old, that's just a tough decision. Yeah, especially for a neuroendocrine tumor, it's not truly a malignancy.
I'm sorry, Sylvia.
Yes.
I'm still concerned about the result of your DOTA-TOC scintigraphy, because it's not concordant with the MRI or the CT scan. You have a staining of all the pancreas, but you have not a lot of nodules in the body and the tail of the pancreas. So I'm not sure that is really relevant. The second point is with this patient, he has a multiple endocrine neoplasia. Did you search for the genetic disease?
Yes.
So he has.
We agree with you. These results, but
we can't hear you.
Result was strange for us also. So we performed genetic tests, and the result. I'm so sorry, my internet was well, but not now. Are you hearing me now?
Better now.
Are you here? our internet connection, it was, I don't know what happens here. So we agree with you, and we performed the genetic test, and this was the result. The result we have MASH syndrome. So that's why all pancreas has this kind of expression of somatostatin expression. We have a 28 years old patient genetically confirmed with MASH disease, with episodes of symptomatic hypoglycemia, markedly elevated glucagon levels, multiple pancreatitis proven, and we have this diffuse pancreatic somatostatin receptor overexpression in the in the PET scan, in the Dotanoc scan. So
Okay.
But I still would do the calcium stimulation test. And if one part of the pancreas is more producing than the other, then you could do a partial pancreatectomy. I think, I don't know if anybody remembers, but we presented a very similar case in one of our conference. I think it was one in New York, of a patient very similar to that. And we did a distal pancreatectomy based on the calcium stimulation test results. And at least until now, it's been 4 years, the patient is in remission. So this is something to consider, especially in a young patient.
Dr. Bismuth.
Well, in multiple endocrine neoplasia, the
Yeah,
surgery
Dr.
is
Bismuth has his hand.
not, yeah.
No,
Professor Bismuth.
yes. What you said. What you asked to me. Hello, Laurence.
We hear you.
You raise your hand.
I raised my hand.
Yes, you did.
Really? My hand raised. Not me.
Okay.
My hand. No, I was listening. I don't know the syndrome, so I was hearing at you. I have no question.
Okay. So in that type of genetic disease, surgery should be very, very careful because generally we use first the medical treatment to try to reduce the surgery, because the surgery is very difficult. There is a lot of neoplasia within the pancreas. So it's very young, so we have to be parenchymal preserving. So I agree that we have to know what is exactly the insulinoma which is really secreting. I agree with Dimitri. Now more and more, particularly in very small lesion deep in the pancreas, radiofrequency can be used, and it's the first step maybe to see if for example the little one in the head could be radiofrequenced. That's a good option in this patient. See what happens after, and then try to localize exactly the lesions. But it's very rare to have this genetic disease with insulinoma. It's very rare. Usually it's endocrine tumor, non-secreting endocrine tumor. So I think that the medical treatment should be done first. Then if it's reluctant to that, maybe we have to wait and to try to localize the secreting one. Dimitri, I agree with you. Other invasive procedures should be done to see where is the production of insulin.
But that's a very simple test. It's not something super sophisticated. You put the catheter in different arteries that feed the pancreas, and you stimulate it, and then you take a sample of the hepatic vein. It doesn't require some sort of a super complicated thing. can be
Yeah.
done for almost anywhere, and it's fairly precise. And I'm almost sure. I actually would be very interested to see the follow-up of that, because it's very similar to the case that we had a few years ago. Exactly,
Okay.
almost
Good.
exactly that.
Okay, but I have a question for you. We know that with this disease now we can have a neuroendocrine tumor on the tail and the secreting one on the tail, but tomorrow it could be on the head. It could be multiple nodules, multiple neuroendocrine tumors. So we may treat with the patient now, and in a few months we have another insulinoma and another neuroendocrine tumor secreting. What do you think about that?
Well, my question to you is very simple. Let's say it's like any one of us. Would you look in the future, or maybe you have a problem down the line, versus you have some minimally invasive, simple treatment that can be done right now, take care of the problem and go on with your life. And you don't know how long it's going to take to develop a new problem. Plus, you can you will obviously put the patient on either octreotide, long-acting, or lanreotide, or some sort of things like that, and monitor. Who knows? Like I have several patients with multiple endocrine neoplasia that develop pancreatic tumors, and we've ablated using radiofrequency 3 times already. And this is, I'm talking about, like, I think 12-year follow-up on the patient. The guy who originally came to me, he was 32 years old. Now he's 48 or 46, something like this. I'm not sure. But it's a lifelong process. So I don't know. I would focus on what the problem is today, take care of that, and then go on.
Yeah,
Okay.
Yeah.
Thank you.
I agree. Thank you very much, Sylvia.